we need a village. And this conversation is just making me realize even more, like, I need a force behind me because so many changes are going to happen. We're going to go through life. Today, we're diving into a topic that affects every woman at some point in her life, and yet is still so misunderstood. We're talking about menopause, perimenopause, and everything in between with our guest today, Dr. Vickie Mello, a seasoned OBGYN provider who spent 2 decades walking with women through every stage of life. Dr. Mello, I'm so glad that you're on the show.
Thank you for having me.
Awesome. So how's your energy today?
I feel good.
Yeah.
I'm excited.
I'm excited for this conversation because, as I was telling you off camera, I've been having conversations with women in my life and learning more about menopause and different issues that affect women. So I'm excited that I get to pick your brain today.
Well, it's exciting for me to be a menopause provider because a lot of people come in with different issues of menopause. They're not all the same. You know, not everybody experiences menopause the same. So it's really fun.
I've heard there were some women in my family and they were all having conversations and like, I was like, is this what I have to expect? I'm so nervous, but thank you for sharing. So yes, I'm excited to dive in. But before we get into it, I know that we have some male viewers and male listeners on the show, and they might be tempted to skip this episode because it's involving women's health. What do you think is essential for men to be a part of this conversation? What will they hear today talking to you?
Well, I love it when my patients bring their partners with them. Usually they don't stay for the whole visit, but you know, to be there for your loved one and be supportive and learn as much about what's going on with their health as you can, that's really invaluable to a lot of women. So some of them have partners, some of them don't. Some of them are male, some of them are not. But definitely, you know, you need supportive people around you. That's part of what we recommend for healthy aging.
I love it. So, you know, you decided to go into health. You pursued this medical path. What was it about obstetrics and women's health that attracted you?
Well, so I'm the youngest of 6 kids.
Wow, the baby.
Yeah, and I became an aunt at age 12 and was learning about all the different health problems the women in my family were experiencing. And so I knew that I wanted to go into women's health at a young age. I didn't really have an interest in menopause specifically until I started to get of that age and didn't really enjoy all the things that were happening to me. And so I was learning more about it for myself because we learn in medical school, and I think it's changing now, but we learn a lot about what can go wrong and when people get sick, but we don't always learn about what naturally happens and how that affects people's day-to-day lives when it's, you know, a natural process, and we should be able to get through it with no problem. And that's not always the case during that transition. Perimenopause, menopause, people have a lot of issues that affect their quality of life. And sometimes they just come in with questions like, is this normal? You know? And so it's nice to be able to connect with people and kind of reassure them that they're not going crazy and that this doesn't last forever. And then some of the things that they're going through, they don't have to live with, that we can offer them, you know, some assistance with that to live better.
So you said you were the baby of the family. So was there anyone else in your family that decided to go the medical route?
No, I'm the only one. My mom actually was, well, let's see, she was 19 years old in Detroit when she got pregnant and got married in that order and proceeded to have all these children. But she had to drop out of nursing school at that time. And so she worked until like I was 5 years old. She stayed home until I was 5 years old, and then she went back to work. And then eventually, when she retired from Kmart, she went back to school for medical assistant.
Wow.
To kind of live her dream. And so I was already interested in medicine. Actually, I'll say the thing that made me think that I could ever be a doctor was an 8th grade teacher. So
what happened with the 8th grade
so
teacher?
I'm
curious. I need to know
Mrs.
the story.
White, and this is in Lapeer. I didn't grow up very far from here. She was a 7th and 8th grade science teacher, and she was also a volunteer ambulance driver. So her and her husband both, they would have the students in my school come and learn CPR and stuff like that. And I had interest, and I was good at math and science. And so she told me at that time, she's like, well, you could be a doctor. And I was like, really?
Yeah.
So,
Yes.
I mean, that's the thing too, is it only takes one person to kind of motivate somebody or put that dream in motion. And so that became my dream.
Yeah. She like planted the seed
Yeah.
and along the way just got water.
Yep.
And I feel like you also honored your mom by going into the medical field.
Yeah.
Do you think you inspired her to go back?
Yeah, but she inspired me too, because I mean, she didn't work in medicine for a long time, but she was always, really moms are kind of like the first line of healthcare for their families. And so, they have to learn a lot about, when to call the doctor, how to treat before you need a doctor and stuff like that.
Yeah.
So, she was that person for us.
And you're taking care of women through every stage.
Mm-hmm.
What have you learned over the course of your 20 years? I'm sure so much.
That's a loaded question. I mean, there's so much. I think about, that I had a good education. I had a good training in OBGYN, and I was definitely capable when I came out into practice. But a lot of the things just the perspective I have, I think has changed as I've gotten older. More compassion. I thought I had compassion, but you really don't see until you've seen some people go through some stuff. And also just like, realizing for yourself and your family how lucky you are. Yeah. Because you see a lot of good things, a lot of births and beautiful moments, but also a lot of sad stuff that you're thankful you haven't had to endure. So
that's good. And I like the fact that you talked about being compassionate. I think sometimes as a patient or someone on the opposite end, when they're only getting that 15 minutes with their doctor, it feels like, are you listening to me?
I mean, over time, I've learned the importance of the nonverbal communication too. And I mean, about it, but to make it work in your favor so that people do feel comfortable, they don't feel judged. We're there to take care of people. And sometimes that feeling like you're going to be judged gets in the way of being able to take good care of people. So worked hard on that.
That's
over
good.
the years. And I try to convey that. We teach a lot, at CMU, students and medical students and residents. So try to be that role model for those folks too.
That's good. I love that. And she talked about CMU Health and it's a training environment for the up-and-coming generation. And that's what you're doing too. So again, you've been practicing for over 20 years. What are some of the biggest shifts that you've seen in women's health? I was talking to a colorectal surgeon, and they had mentioned that there are younger people being diagnosed with colon cancer.
Oh, yeah.
So for, in your corner of medicine, what are you seeing?
Well, first of all, like in my, professional area, I trained all my mentors, just about were all men. So total shift, really. I remember I went out into practice, and there was one female that was, middle age, I'll say, and the rest were male. I mean, that change in and of itself has been amazing to see, and there are still male providers, and they definitely play a role in our specialty. But I think having more female providers available for women has been a big, huge change. It's not perfect you're not, just because they're female doesn't make them a great doctor, but I think that's a big shift for me. I mean, working in the profession, I've always worked with a lot of high risk populations. I trained in Flint and then came here. Oh, I actually did like 3.5 years in Dyersburg, Tennessee too. I was paying on my student loans and got recruited out in very rural.
Wow. So when you say high
place.
risk, what does that mean?
So lots of different things make people high risk, but I'd say people with histories of poor obstetrical outcomes, underlying medical conditions, and we've seen people having babies older, but our population tends to be not necessarily the healthy older women, but some people that, first of all, had a hard time getting pregnant, and then, have other medical conditions. One of them, I mean, you've talked on this show about obesity.
Yeah.
And the number of people and the actual, that's a broad range of patients, just saying obese. But you're talking about, patients that we used to say were overweight at a certain weight, but now we're seeing people that are going around pregnant twice that. So it's a lot to take on, a lot of complications, and it's not always easy to take care of folks.
Something that's kind of come into my head when you're talking about high risk, and then we're talking about obesity and these certain outcomes. Do you tie that also into the area? Like when you think about Saginaw, if you go to the city of Saginaw, it's a food desert. They don't really have
Yeah.
many grocery stores. So is there like a tie-in there as well?
I'm sure.
Okay.
But I think it's a national problem, but like
Yeah.
there's different subsets of that community. My daughter recently had a baby. She's out in California in LA County. She lives in San Pedro, her and her husband, and that environment that she was in, the practice that she went to, the hospital she went to have the baby, totally different.
Yeah.
And a lot of it is just the type of patients and their health issues that go to that hospital and that live in that area. But I think there too, I got the, it seemed like, I don't want to use the word segregated, but different populations go to different places,
Yeah.
seek out different care. And so I've always been in a practice that takes all kinds, doesn't dismiss patients from their practice on a regular basis because maybe they missed appointments, especially OB patients. We don't dismiss OB patients because if they come to the hospital, we're going to have to deliver them anyway.
Right.
So we take all comers, and we get patients referred to us and shipped to us at the hospital. We take transfers when they're at an outside facility and they can't take care of them.
Yeah.
So, all kinds of stuff.
I like that you said that too, referring to CMU Health specifically, but you also do work at Great Lakes Bay.
Our group of faculty covers Great Lakes Bay in Saginaw. So there's a Great Lakes Bay in Bay City that deliver at a different hospital, but the Great Lakes Bay patients that want to deliver at Covenant, we take care of.
Yeah. And that's awesome, being able to reach all communities.
Yeah.
And I do agree with you. When you go to certain areas, it does feel like that.
Yeah.
I don't know if we can ever change it, but
Right.
yeah. So, you talked about the menopause. You recently you decided to get certified in this specialty. What motivated that decision?
Mostly my own going through that. I'm 54 years old, so I'm now seeing sort of the other side of it.
Okay.
But a few years back, I was definitely struggling with some of the changes that were happening. And I think certification is, I knew a lot about it. I could do my own reading about it, articles and, stuff like that. But I think the certification for me was also a way to kind of get confirmation that I did know what I was doing, and that because you take a precepted test. It was actually like now too, like I didn't take to my boards, like they are now where they take them virtually and everything. So this was somebody signing into my computer and being able to see me while I take a computer test online. I mean, I had never done anything like that. Yeah. So, trying to like keep up with things, I think that's part of why I love working with residents is you have to be on the cutting edge and you see, all the new stuff, and you're a part of kind of sifting through that because it's not all great information.
Yeah. So how long did the certification take?
So I think I had to apply like 3 months ahead, and then they set up that precepted. They have like another subset company that does that they're making sure you're not looking stuff up while you're taking this test and stuff like that. I guess. And then you just wait for the results. And then there's a maintenance part of it too. Like you're supposed to do a certain number of continuing medical education on menopause.
Okay.
So, yeah. I mean,
now, is this something that most OBGYN providers do they go through this certification?
No.
So you're like the exception.
Yeah, I mean, most of us are trained to some extent in menopause and see menopausal patients, but myself and Dr. Sundstrom are kind of the people that put it out there. Like, this is an interest of ours. We want you to come and spend time with us and talk about your menopause issues. Whereas some providers are not as comfortable and maybe don't put that out as the thing that they like to. We call it a niche.
But why though?
Oh.
I mean, especially if you're taking care of women through almost every stage of their life,
Yeah.
why not learn this information?
I know there's so much to learn. I don't think it's that they don't want to learn about menopause. I think there's so many areas. Some of our attendings are interested in infertility. That's not something that I've had more training in. So I tend to send my patients who have infertility issues to that provider. So we're all generalists, and it's not that we won't see it, but it's nice to have a group. I think we're up to 8 now, where certain people have certain interests and have done more training or seen more patients in that, and it's kind of nice to be able to do that.
That makes sense. Now that you explained it that way, I'm like, okay, that makes sense now.
Yeah.
Everybody has their own niche and specialty, so completely, I get it.
We're all at our practice. We're all generalists. There are, you can do fellowship, and there are specialists, subspecialists, urogynecology, gyn-oncology, infertility, and sometimes we send people to those specialists, but they're just not as available.
Yeah. Well, I'm happy that you got the certification, like I said, because now you're here and we get to talk.
Well, and honestly, I didn't really do it for this, but people have now sought me out, which I was surprised about. I don't know why, because that's not why I did it, but because maybe they even have a generalist OBGYN that they see, and they're like, yeah, but I wanted to talk to somebody who knew more about menopause, so they just come to me for the menopause, and then they go back to their provider.
So they can do that. They can just come and have that conversation with you. So what does that look like? Is that a referral that they would have to make?
Well, it depends on your insurance.
Okay.
A lot of the private insurances don't require a referral for that.
Gotcha. Well, that's good to know. And for people out there who is interested, you can just go and have that conversation and go back to your other provider.
Yep.
So what really sparked this conversation, or even wanting to do this episode, I had saw an article about Halle Berry, the actress, and she was misdiagnosed. Did you hear about it?
No.
Okay. Let's talk. So because it was so fascinating, and her doctor actually misdiagnosed her with herpes. And that is just like, it's mind blowing to me. But it turned out that she was just actually going through perimenopause. So,
and she had a rash?
I think there was, look, now people have to go and look this up because I'm only going off the top of my head and based off what I read. But I think she was maybe experiencing dryness and maybe like itching or rash or something like that. But definitely go and Google it. I don't want anything to happen when people are watching or listening to this episode. But she was misdiagnosed, and her provider was like, yeah, this is the worst case of herpes. Didn't even do the test yet, just told her that's what she had. So, of course, her and her partner are nervous. They eventually get tested, find out that they're negative, but I don't know if her provider ended up, making the new diagnosis, but she finds out that she was just experiencing perimenopause.
Wow.
So I'm curious as to, how does something like that happen in modern medicine?
Well, I mean, people are not perfect. These are providers who are people. But also, I've never heard of anybody having a rash that looks like herpes and sounds and feels like herpes because of perimenopause. So there are things that happen in perimenopause, the change in your hormones, that make people have some skin conditions and symptoms. Yeah. That would be, itching or dryness. That's totally understandable. But to have a rash that looks like herpes, I would have to see that.
Yeah. Like, show me the picture.
I mean,
yeah.
And herpes actually is, the thing is, let's talk about that, because that's very prevalent. And honestly, STIs, sexually transmitted infections, are going up even in older people. So, because people are, living healthier, they're having other partners, it's very prevalent, and it doesn't really get cured when we treat it. So you can still transmit it. So it's one of those things people don't like to talk about. So it's nice to have, I think, us that you can come and talk to. We keep things on the down low. Nobody wants to share that information with a whole lot of people. But anyways, it has a very specific presentation, usually a look to it. And the test for it to do on the swab on that kind of rash sometimes doesn't show it.
Gotcha.
You actually have to have some kind of fluid, like open vesicles is the ideal, where they have like seeping some fluid and you can swab it.
Mm-hmm.
The test that we have, there is no good screening test for herpes. The test that we have, that's a blood test, tests both HSV1 and HSV2.
Mm-hmm.
HSV2 is the common strain that affects the genitals, but HSV1 can too. And
You're
that's
blowing my
that's
mind.
the confusing part. So say you get a test back that says you've been exposed to HSV1. It's a blood test. I can't tell you whether it was from your, cold sores that are
Yeah.
HSV1, or if you've had something on the genital area. And then other people are like, well, I didn't see anything, but you can't see your cervix. It's up inside. So it's
So would they just come back for like retesting?
yeah.
Is that how
I
it
mean,
works?
ideally you test the actual vesicles when they're there, but a lot of times we don't hold back treatment because that's a very painful
Mm-hmm.
rash, and so we give those before we have confirmation because we want people to feel better. So misdiagnosed, treated empirically was probably more what happened, and then they did other testing and found out it was something different, maybe.
Mm-hmm. Yes, according to the article, it said that her and her partner went to get tested and they were negative,
Yeah.
and then she was just actually experiencing perimenopause.
Oh wow.
And so now she's like on this full-on campaign about these conversations.
Yeah.
And I think the conversations have been happening, but of course, she's a celebrity, so it's on a bigger platform.
Yeah.
And now it's just opening up my eyes, and I'm like, I want to know more as well, So
Yeah.
very interesting. So again, is misdiagnosis, is that a common theme?
Well, so I don't know what happened exactly with that, but when you come and see a provider, and I also want to talk about what is perimenopause. too.
Yes, please,
But,
because that's my next
yeah.
question too. I want to know the difference between.
So I'll just say, when you come and see a provider, especially a gynecologist, say you have a rash, we look at it and we examine you and we talk about, getting your history and the ins and outs of that rash. When did it start? What did it feel like? Things like that. What made it worse? What made it better? And that, that's about using your medical judgment to see, what it might be. So we have a
Yeah.
differential of different things that it could be, most common and then less common. And so, and then you're talking about something that's maybe a painful rash. If they thought that the most likely thing was herpes, they're going to start treating you for it. But you usually do test it, and it takes time to get those tests back. So I don't know. Sometimes it takes, what we'll do is we'll say, okay, try this. And if this doesn't help, because ultimately it's kind of the vulva itself is kind of dermatology. And so ultimately, dermatologists, when you go and see them, if you've ever saw them, they almost always biopsy. And we like to biopsy too, but most patients don't want us to biopsy their vulva. It's a very sensitive area.
Yeah.
If you can figure out what you have and get treatment without the biopsy, that's what most people prefer. So usually we do swabs and, get that information, especially infections. But there's other things, dermatoses that can happen on the vulva that sometimes it's just trying like a course of steroid cream and seeing if that helps. So we bring people back in a couple weeks, I don't know what
That
happened with
sounds
Holly
like a
Berry.
lot. I'm not looking forward to it.
Yeah. I mean, I think the best thing as a patient you can do is keep asking questions and keep coming back. There's electronic medical record. You can send a lot of messages versus, over the, like we have My Chart at Covenant. And if you're not, if you still have questions, you're not sure what you were supposed to do or, anything like that, you can always send a text. So that's a nice thing.
Yeah, that is being able to communicate with your patient.
Yeah.
So can you explain the difference
yeah.
between perimenopause and menopause?
So technically, and it's kind of arbitrary, but how we define menopause is that you haven't had a period for a year. So, and the average age in this country is age 52. Some people go through it much earlier. Some people go through it later. And then sometimes people start going through perimenopause in their 40s.
Okay.
You can have premature or early menopause, but that's usually like an actual disorder. It's not normal to go into menopause when you're 35, So that requires additional testing to see what's going on there.
This episode is sponsored by CMU Health. With 8 clinics across the Great Lakes Bay region and surrounding areas, CMU Health provides care for patients from newborns to older adults. Quality healthcare close to home. To learn more, visit cmuhealth.org. Now, what does the testing look like?
Well, so
Is that just conversations? And
yeah, I mean, a lot of times, if people are still having periods and they're having regular cycles, they're probably not menopausal. But do they have some symptoms that sound like perimenopause, and then or problems that could be perimenopause? We would need to address that too. I mean, in general, though, we try to rule out things that are could be life threatening. So maybe you're 45 and you're missing cycles. Maybe you go like 2 or 3 months and no period. It could be perimenopause, and then you could just kind of say, oh, okay, so your body's kind of winding down and getting ready to stop having periods. But the other thing it could be is diabetes. And so that's the testing that's really involved, is making sure it's not something that's, more worrisome and needs addressing. So,
okay. So many health factors.
yeah, I mean, I talk about periods, but there's a lot of other symptoms that people come to our office with.
So what are some of the other symptoms?
So the most common is just abnormal bleeding,
Okay.
and a lot of times heavy periods. People complain less when they don't have a period, although that could be a problem.
Yeah.
But painful or heavy periods lasting longer than they should, and then pain. Maybe it's a skin issue. Maybe it's pain with intercourse, and it can be other things too, like people, maybe are having more mental health problems than they have in the past, and they're kind of looking to see, is it their female hormones, So that's a whole area, by the way, of testing hormones.
And it's so much is coming to me because when you
Yeah.
just talked about mental health, again, I was having conversations with some women, and they were like, the thoughts I was thinking, and it was like really bad and negative. So is that a thing for women going through perimenopause or menopause?
What you have in perimenopause and in menopause is these kind of, usually perimenopause, because the transition to menopause is really what kind of throws people for a loop, because you can have, from one day to the next, you could have normal to high levels of estrogen, and then a few days later, your estrogen levels are really low. So it doesn't always just taper off very smoothly. Sometimes you'll have, months that are like they were, you're ovulating, you have your period, and everything's kind of how it used to be. And then and then maybe you have like some wacky stuff happen that you're like, this has never happened to me before. And, maybe an episode of really long period or no period, or like I mentioned the periods, but maybe you're feeling really bloated or, swelling, and then that goes away. And you're like, what the heck, So, but perimenopause looks like other things too, like hypothyroid and some other different things that can cause those same symptoms. So a lot of times we're just spending times ruling out other things.
Okay.
And then kind of coming back to perimenopause and saying, okay, if that's what it is, what can we do to, help?
Now, you brought up hormones. What would that testing look like? So if a patient comes in telling you some of these symptoms, you're trying to rule it all out, do you refer them for a test to test their hormones?
So a lot of times people will come in saying, can I get my estrogen level or progesterone levels tested? And it's really hard because, like I said, that could be a fluctuation from day to day. When somebody hasn't been having periods, or maybe this is the other time I order it more often, maybe they've had hysterectomy at some point and they still have their ovaries. And so menopause is really when your ovaries kind of shut down, your estrogen levels go low. And they're like, am I there yet? Am all these symptoms, am I in menopause or not in menopause? And if we check some of the pituitary hormones, follicle stimulating hormone and luteinizing hormone, FSH and LH, we can tell when they're really high that you are in menopause. But until you get there, there's not a great test. So sometimes people come in, maybe they're still having irregular periods and they're perimenopausal, but they're also having hot flashes on occasion, or night sweats, or mood changes that they're like, I'm really irritable, or I can't sleep well. And so we talk about some of the changes that can occur and some of the things we can do for those. Because just making your ovaries, the thing is, like, sometimes we'll give something like cyclic estrogen and progesterone, and usually that's in the form of birth control pills because it's already packaged that way. So we can do that so that you can kind of even out your hormones. But but there's, lots of other changes in perimenopause. And some people just don't like the idea of going on other hormones because their hormones are up and down.
Yeah.
So
I'm just like, wow, as a woman, like men just,
I
they
know.
kind of like coast through life. And
Yeah.
then women, we're just going through
Yeah.
all of these changes.
Yeah. Well, I mean, most men most women are very resilient. Like the changes involved in pregnancy and postpartum are even bigger, really, and in a shorter amount of time. So most women just want to know what's going on. And sometimes we don't end up using any hormonal treatment, maybe ordering a few tests, but sometimes it's just that, okay, yes, that is part of perimenopause. And, how long will it last, do you think? Or, that kind of thing. And, some of that I can, I know the average age of menopause. I inform people that all the time. But when you personally are going to go through menopause, I can't say.
Yeah.
The best predictor is when your, family members did. So if your mom went through a natural menopause, or your aunts, or your sisters, the age that they went through it is probably the best predictor in general.
That's good to know.
Yeah.
So outside, like if a person can't look to their, family members, what is that general or common age? Is it just in the 40s that the perimenopause begins?
I mean, it can start earlier for some people. Some people, there's some things that are natural aging, like presbyopia and, having to wear these glasses because you can't see up close. That typically happens around mid-40s.
Okay.
And some people, it affects them more than others. Like, I mean, reading is a really important part of my job. Other people are not reading as part of their work or day-to-day. So maybe they don't notice it as much. But, I mean, that's one of the changes that occur in your 40s. So there's other changes that are going to occur as you get older. And some people kind of point to menopause, but some of them are just natural changes associated with aging.
Gotcha. And so you brought up being placed on birth control. Are there any other options for women when they're going through
it
this?
depends on what their symptoms are and what they need help with. Like if it's night sweats, hot flashes that they're coming in for, there are a number of different treatments, some of them hormonal, some of them non-hormonal that are available. And there's new ones coming out every day. So I think there's probably more in menopause medicine than there ever has been before. And maybe that has something to do with the fact that more physicians are women. I don't know.
That's interesting to know. And that because I wasn't able to ask you that question earlier when you talked about the shift. I wasn't expecting you to give that answer regarding just seeing more women in the profession versus men. That wasn't the answer I was expecting, but that is so fascinating. So you would kind of attribute.
I mean, it's an assumption. I don't like to make assumptions.
Yeah.
But there's definitely been a shift in the culture from the places that I've practiced at, I'll say.
Wow,
So
that is fascinating.
it's more patient-centered, more women-centered. I think that's the way I like to practice is you're taking care of the person in front of you and who they are. You're not like, and you're also learning from them what they want out of it. You're not going to tell them, like you said, what the treatment is. It depends on what they want out of it.
Yeah.
So if they just want information, then that, you don't have to do anything except give the information. So, but there's all these different issues too. Like maybe they're having problems losing weight. We mentioned that again. Maybe they're in their mid-40s and they're like, I never had a problem with weight until now. And so, they want me to give them hormones to help with weight. Well, some of those are that 1 + 1 = 2, but I can't just like if I give you birth control pills, you're not going to lose weight. So, then I usually look to like the assistants, some of the primary care. I think you had one of the women that I referred to for weight management. You had her,
Dr. Defina.
Yeah.
Yes.
So if people can get in to see her and follow her, that's a great because she's very knowledgeable and she has all these, and a lot of the primary care are now becoming better apt at weight management because we've had some big, changes in that field.
Yeah.
But you may be gaining weight because you're in perimenopause, but me changing your hormones is not necessarily going to fix it.
So if they are gaining weight and they're finally done with menopause, say it's over, right?
Okay.
There's a time it ends,
Yes.
right? Okay.
That they're in menopause, yes. The transition is really the harder part. So getting to the other side, usually people are less symptomatic, I'll say.
Okay. So does it start to like settle? Like, can they start to lose it? How does that
I think,
look
I mean, you can
afterward?
lose weight at any time. You can lose weight in the perimenopause, but it has to do with, healthy choices, healthy behaviors, exercise, paying attention to sleep, all those things. It's not like an easy fix. Even though there's like the GLPs and stuff like that, that will help you with your appetite. But if you choose to eat for other reasons, or you don't exercise, you don't do any weight training, you're very sedentary, I mean, they're only going to give you so much,
Yeah.
There's a lot of behaviors that, and I honestly don't think of health as like, okay, you've reached health. I'm healthy now. It's more of a process, and as life goes on, you're faced with different trials that make it harder for you to be healthy. And so you're in the constant state of kind of learning what's good for me, and then trying to manage and get to that point that you're doing all the things that are good for you.
Yeah.
Because we all live in real life. We don't live in a perfect world.
Yeah, that's true. When I hear you talk about all of these changes, I just see like a woman needing a true team and force behind her.
I think so.
From OB, having that primary care doctor, a mental health coach. I just see so many people needing to support her.
When you said team, I thought you meant like other women around her, because that is really important.
That too.
I mean, the healthcare providers are important, and they can definitely be a benefit, but her community is just as important, if not more important. And that's kind of like centering, about centering pregnancy. And we're actually thinking about doing something like for centering for perimenopause and menopause, so that women of the same age and having the same problems can get together and talk about it and say, oh, she's having the same thing as I'm going through, and then they get the support from one another. I think that's really important.
It is important. I think it's important for all people. Like, we need a village, and I think it's a conversation. When I hear village, it's a conversation that we were even having with Safe Sleep.
Oh, yeah.
And families not having the village and the support, a babysitter to take care of their child, or their grandparents, or the grandparents or caregivers. We need a village. And this conversation is just making me realize even more, like, I need a force behind me, because so many changes are going to happen. We're going to go through life.
Yep.
Yeah. So this very just fascinating stuff right here. So as a partner, they have a husband or boyfriend, what should they be doing? How should they support their wives or girlfriends during these moments?
I mean, I think when I see people who have really good communication with their partner, I think that helps a lot. So, when women are having different issues, let's talk about sexuality and sexual function, when they can talk to their partner about, I'm really not feeling it. Like, I don't have the sex drive that I used to, and it's not because of you. It's because I just don't have the sex drive that I used to. And maybe they're coming to me, but they also need to talk to their partner about that, and they need to be kind of understanding and supportive of getting help, and kind of understanding that women, they're, first of all, some of that is part of normal aging, but also there's other ways to show affection. There's other ways to be close, and then trying to get help for that woman. Maybe not with the expectation that she's going to be like 30 again, and things are not going to go back to how they used to be, but they can get better.
Yeah.
And so that's kind of, we kind of set expectations that, it shouldn't be painful for you to have sexual function with your husband. And then also there are other alternatives, because a lot of times even the partner, I tease them all the time. We joke about this, that they talk, the older men talk a lot about that they want to, and they're really excited about it. But then when it comes down to it, a lot of them have health problems of their own. And so, I think that the key is the communicating, though, between those folks, and having some grace for your partner, that, that she's not just holding out because you didn't clean the dishes, like that. And also, like, recognizing that there might be a different expectation as you get older, and what, talking about what's their goals, or what would really make them happier, or, those kind of things. You know, it's pretty complicated, I would say.
It is. And it also makes me think about, I was having a conversation with Kelly Ellis, our nurse practitioner at CMU Health. Just, she goes through the phase of pregnancy, and then having to see the transition of couples sometimes after having the baby. And it's just like these difficult moments, and it goes back to just communicate.
Yeah.
But it sounds so easy, but it's so hard.
It is.
Yeah.
It is hard.
Yeah. But
yeah, I think, I mean, that's it. Kelly does centering, and that's part of what I love about centering is that as they're going through it, like they're, usually the partner is going to a lot of those visits, is hearing about topics that maybe they hadn't even thought about would be an issue for them, like postpartum depression, and what to watch for in your partner and stuff like that. So that's what I love about that program is the guys don't necessarily go to that to learn about that, but they do get that information. And I think that that helps with, okay, is that what's happening now?
Yeah.
When they learn the difference between postpartum blues and the hormone shifts and what can happen in that first 2 weeks, maybe they're a little less judgmental
Yeah.
and more supportive and trying to get their wife as much sleep as she can in this time where it's very difficult that first few weeks and she's going through these big hormone shifts. So a lot of times we don't see the partner with them for whatever reason. I mean, they're coming in for their gynecology, it's not someplace that most men hang out.
Yeah. So when do you expect, because I know you just said you're thinking about or having discussions, do you think this is something that you're going to get started on, these group sessions?
I think Dr. Sundstrom was trying to get certified in menopause medicine as well.
Okay.
And I don't know. I would love to do it. Maybe we could do it in the centering pregnancy room.
Yeah. I think that'd be a great idea.
Yeah, I think it's pregnancy is a beginning and an end. And, perimenopause, menopause, we wouldn't be doing it like that. We'd probably be doing it maybe quarterly throughout the year, but talk to Dr. Shaheen for me.
Will do. Because I do think there's women out there who are really like in this stage now, and they want the information.
Yeah.
So it's very helpful that you've been able to
and
share
I think that the other thing that's happened in our culture and our, in medicine and in health is that people no longer just want their doctor for when they're having a health problem. They want their doctor to help them stay healthy.
Yep.
And that's a great thing. And we want to be able to do that. Mm-hmm. And so a centering program like that for perimenopause and menopause, I think, is just that. It's about staying healthy and getting through that process that is a normal process. But obviously, a lot of people have difficulties throughout it. So
what happens... This is my brain. But what happens once it's over? What is it? Smooth sailing after that?
Well,
what happens then?
I mean, it's hard to say because then, like I said, there's a lot of the normal aging that is happening. So, like for instance, weight management. I was just looking at something the other day where they talked about what was it? Sarcopenic weight loss or obesity or something like that. And I was like, what the heck is that? And then I realized it was just a fancy term for when people lose weight, and a lot of it is muscle. And so as you get older, especially after menopause, a lot of people who aren't paying attention to muscle are going to be losing muscle and become weaker. And so, you start, I think it's a great time if you haven't already to start doing things that help you retain that strength and mobility and flexibility because you want to continue to do those things and you look forward to doing those things that you maybe in retirement or semi-retirement or whatever that you want to, the quality of life. So
I was reading that and it said that women's bones become more fragile.
I mean, you can definitely get like osteoporosis and that's one of the benefits of estrogen hormone replacement or hormone treatment is it can reduce that risk for osteoporosis. But even without osteoporosis, if you're not paying attention to muscle strengthening, maybe you're just doing cardio, you're not exercising at all, you will continue to lose muscle over time. And then, by the time you're 60 or 70, that's when you are, then seeing a lot of people having falls, different, mobility problems.
We were having that conversation in the first season, and I think it was a woman on the show who was saying you need to get into strength training.
Yeah. And it doesn't have to be weightlifting. I mean, a resistance training is. Okay. And I honestly, that's not something I enjoy doing, or I haven't found really a kind of strength training that's that I really like to do. Yeah. So, but I know I have to do it, and so that's the key. I think is kind of trial and error and finding something that you can really do, put in your life on a regular basis. Yeah. I'm doing more biking, but I don't. at times I could do like a 6-week, strengthening, but then I'm like, I'm done with it.
Time for something else.
Which is
Nothing's
not
wrong
good.
with that though. Like, I think it's good when your body, it causes those little changes,
Yeah.
because sometimes it becomes like right now I feel like I'm at a plateau.
Yeah.
And I was like, I need to change.
That's what
up
they say.
something.
You're supposed to change it up.
Yeah.
So I don't know. I'm trying to get into pickleball too, but I need some people to play with.
I haven't gotten into that one yet. I drive past the court a lot though.
Yeah, I haven't gotten into it. My son and I would play, but he's now in the Marines, so I can't play with him anymore. So
Yes. Oh, well, you're now a grandmother.
yes.
Yeah. So what are you looking for now in this next stage? Whether that's in work, do you see yourself going another 20 years? What's the thought process?
I have thought about this, and I'm sure a lot of people do. Think about, when is a good time to retire? Do I want to retire, or what could I do? How could I change my my job so that I can still do it well and stuff like that? Because honestly, my job is there's a lot of hours, but there's also a lot of like sleep deprivation.
Because are you still delivering babies?
Yeah, and I still
Okay.
take calls that we are in the hospital for 24 hours at a time and stuff like that. So I don't think I'll be able to do that for ever. I've seen people do it until a lot older than I would think, but I do definitely want to take care of women still. And one of the things I enjoy now is also mentoring other faculty people and residents and stuff like that. I keep hitting that. Sorry. So I get a lot of joy out of that. And if I stopped altogether, I think I'd be really missing that joy in my life. So, trying to figure out over the next, 5 to 10 years, how I want it to go.
Well,
I don't have the answer.
This conversation has been very enlightening. So I definitely see that for you, having more of these talks and conversations around menopause, especially because I think it's still something that we're trying to learn as a community. And like I said, to go back to a Holly Berry story, who is a celebrity, I'm sure she has some top provider in that area who still got it wrong. So I think the conversations still need to be had.
Yeah. Well, and I would say too that that we expect a lot out of our providers, and our providers are more well trained than they ever were. But I think if you're trying to make sure that somebody's not making a mistake, you keep asking questions and you keep going back and saying, I don't think that's right. Is there anything else it could be? I think in this day and age, you have to be your own advocate for sure.
I'm happy you said that.
Yeah.
Yeah. We don't hear a lot of doctors say that, but yes.
Well, like one of the things that's changed, you asked me about how things have changed. I think it was maybe a year ago where in Michigan, Medicaid started paying for doulas, which are, just people not with a lot of medical background that are there as a woman goes through pregnancy, labor, postpartum to be supportive, basically. And that's actually evidence-based that people who have doulas have better outcomes with the mom, better outcomes with the baby. And so, we're paying more attention to things like that maybe we didn't think of as really science or medicine or anything like that, but really, help people's health. Yeah. So that's one of the really good changes that Michigan has made, I think. I don't know about other places.
I think so.
I mean, my daughter had a doula in California, but she had to pay for her. So I don't know that it's, covered the same way.
Mm-hmm. Yeah, I think it's a great program. Some great doulas out there, especially in our community, that's doing fabulous work. And we're bringing on, I think, doulas in our own.
Yeah, at CMU Health.
At CMU Health. So this is awesome. So before we wrap up and before I let you go, what's one thing you wish every woman and the people who love her understood about menopause? And I know we had this entire conversation, but as we wrap this up.
Well, I think I think keeping in mind that it is a kind of a natural process, that's important, but that doesn't mean that you have to live with all the things about it that are making it difficult for you. So some people experience mild hot flashes or night sweats, and some people don't, have any, and that's great, and they don't need to come in and see me about hot flashes, But if you're having such hot flashes or such symptoms that it's really affecting the quality of your life, when you haven't been able to sleep good and however many days, that you don't have to live like that. So I think those are the things, the same goes through like things like incontinence. As women get older and they've had babies, sometimes they leak a little. And that's okay.
Yep.
But if it's to the point where, you're having to wear a pad all the time, you can't go exercise because you leak every time you try to exercise and it's embarrassing, come and see us about that. You don't have to live like that. So
I know somebody. Go see her. Thank you so much,
it was
Dr.
nice
Mello.
to talk with you too, Alexandria.
This was amazing. Thank you so much.
Yeah, you're welcome.